Topic for today's discussion is imaging of bony pelvis as distinct from, say, soft tissues of the pelvis or pelvic contents, including uterus, ovaries, etc. So in bony pelvis, the bones involved are majorly two innominate bones, sacrum, coccyx, and heads of the femur, including the necks and proximal shafts. These disorders of the bony pelvis can be divided into developmental causes or congenital causes, traumatic, infectious, inflammatory, metabolic, hemopoietic, neoplastic, or miscellaneous. But in the course of this orthopedic session, somebody else is talking about traumatic, metabolic, and neoplastic. So I will exclude them and confine myself for the rest of the entities. What are the imaging methods? The usual methods, conventional. AP, view of the pelvis, which is comfortable. PA occasionally, and oblique views for the sacroiliac joints mainly. CT, it is spiral CT or conventional CT or multi-detector CT. MRI, magnetic resonance imaging. Ultrasonography, nuclear medicine, angiography, and PET scan. This is first we will see the normal variants. These are the pectineous muscular attachments, simulates a periosteal reaction along the superior margins of the pubic bones. It is normal. Now we come to the disorders of bony pelvis. What are the systemic disorders? Any disease in the body may reflect, say, metastasis, myeloma, benign tumors. All these may reflect upon the bony pelvis. Local causes of the bones and joints, bones, tumors, trauma, joints, any type of arthritis. Amongst congenital or developmental causes, bone dysplasias form the biggest chunk. Sclerosing, the manifestation of the bone may be sclerosing, lytic, or mixed both sclerosis and lytic. Generalized homogeneous increase in bone density, there are certain conditions, osteopetrosis or marble bone disease, pycnodysostenosis, osteoporosis, osteopathy striata, malariastosis, Engelmann's disease, idiopathic hypercalcemia. There are others also, but these are the major entities. One on your left side is diffuse density, so-called marble bone disease. The right thigh is in a splint because he had a fracture of the mid shaft of the femur. Similar lesion on the left side also, but this is pycnodysostenosis. How can you make a difference? Frankly, in these bones you can't make a difference. But if you take the entire skeletal series, namely the cranium, there are midline defects, open anterior fontanelle, vermian bones, and then if you take the chest, dysplastic, partial or complete absence of the clavicles, pubic symphysis, there may be a defect. So these are some of the differentiating points between marble bone disease and pycnodysostenosis. But if you take pelvis alone, you can't make a difference. Osteopoikilosis are the so-called spotty bones. You get multiple spots, rounded or oval, and this is supposed to be inclusion of the cortex in the sponges of bone. This is more often frequently seen around the joints. Why do you need an MRI? Just to show the appearance of MRI, multiple lesions, marrow extension, high sensitivity, soft tissues. Soft tissues are not generally involved in osteoporosis. Spinal canal contents. In order to see all these, you say take an MRI. And this is osteopoikilosis. Suppose if you see one or two, commonly you see in routine examinations, they are called bony islands at multiple places of no significance. Then comes the entity malariastosis, flowing sclerosis. Look at the pubic bone, acetabulum, and along the medial margin of the head, neck, and shaft of the femur with soft tissue calcifications. Sometimes you see skin changes also. The appearance on the shaft of the long tubular bones, it is likened to a molten wax flowing along the candle, dripping wax along the burning candle. Then comes the entity called fibrous dysplasia. It could be monostotic, polyostotic, and Albright's syndrome, that is polyostotic, particularly in women with sexual precocity and skin pigmentation. Radiological appearance in fibrous dysplasia, that is monostotic or polyostotic, ground glass appearance of the matrix, lytic area with a rind, smoky type of matrix, sometimes calcific matrix, that is rare, then we call it fibrochondrodysplasia. Thin cortex when it is aggressive, mixed osteolysis and sclerosis in various proportions. For example, take the pelvis and the proximal ends of the femora. There are lytic changes, bilateral, although not symmetrical. Particularly look at the neck and shaft of the right femur on your right side. This is described as shepherd's crook deformity. Occasionally you may see the fractures also. Then comes cleidocranial dysplasia, that is delay in ossification centers, clavicular absence either partial or complete, open fontanelle in the skull, vermian bones. You remember we have described in pycnodysostenosis. This is pycnodysostenosis is supposed to be a hybrid of cleidocranial dysplasia and marble bone disease. Midline defects, poor ossification of the pubic bones. Now the poor ossification of the pubic bones. Then comes Osteogenesis Imperfecta. There are clinically 4 types, but we see mostly in the pelvis osteopenia, fractures, healing fractures, deformities of the bones. Look at the pelvis, softening of the pelvis, so-called autopelvis. And then look at the femora, bilateral curved femora. There are several forms, Osteogenesis Imperfecta congenita, almost lethal in infants. But then tarda you could see in adults. Chondrodysplasia punctata or Conradi-Hunerman disease is another entity where sometimes there is spontaneous regression is known. Stippled calcification at the ends of the bones, calcification adjacent to vertebrae, vertebral deformities, asymmetric shortening of the long bones. See, look at the punctate type of calcification in the sacrum and coccyx, also along the iliac crest, along the vertebrae, heads of the femora. This is typical of the so-called stippled epiphyses, typical Conradis. Differential diagnosis in children of mothers taking anticoagulant therapy also you may get the same thing. Again, there is spontaneous regression in most of the cases. Then comes Pile's familial metaphyseal dysplasia, dense expansile metaphyses, including the medial ends of the clavicles. Another entity is hereditary Unecho osteo dysplasia, so-called Fong's syndrome. Osteocartilaginous exostosis, bilateral, symmetrical, only in the iliac bones, now nothing in the tubular bones. It is also called Fong's nail patella syndrome because there are dysplastic nails and a hypoplastic patella. They are also called iliac horns. Rare, but occasionally you may see. Metaphyseal chondrodysplasia or dysostosis, you see the discrepancy between the head and neck of the femora with a fracture and also fragmentation of the medial side of the neck, metaphysis. Spondylometaphyseal dysplasia, when the spine also is involved, flattening of the spine, deformities in the stabulae, poor ossification center in the metaphysis. Spondyloepiphyseal dysplasia, this is an adult, comes with hip pain, and look at the large epiphysis and narrowing of the hip joint spaces due to degenerative changes. Achondroplasia, which is a common dwarf that we see, small sacroiliac notch, and champagne glass appearance of the pelvis, pelvic inlet actually. Of course, the long tubular bones, you get dumbbell-shaped bones. Mucopolysaccharidosis, I don't want to dwell into it because it's a long, complicated, and confusing process. Because there are lots of time, there is superimposition of one over the other. Ultimate laboratory analysis of the mucopolysaccharides in the urine gives the diagnosis with correlation with radiological findings. Kakarla, 19-year-old short-statured male with deformities, Look at the hands, radiographs of the hands. Trident hands with coarse trabecular pattern. Pelvis, ilia are flared with obliquity directed acetabular roofs. Coxa vara or valga also may be present. This is typical of a Hurler syndrome. Inferior beaking of the vertebral bodies that you see in the lateral view. Look at the deep acetabulae and dysgenesis of the epiphysis. Another case of Hurler. Spectrum of findings. Marchio. In Marchio, the differentiation is in the vertebra, if you take, there is central beaking. And almost the findings are almost similar. Look at the vertebra plana and deep acetabular cavities, flared iliac wings. This is the description of Marchio syndrome because all these Marchios is a little more common. Now we come to the group of phacomatosis. There are several, but tuberous sclerosis, neurofibromatosis, cystic angioimatosis, Sturge-Weber syndrome, von Hippel-Lindau, Gardner syndrome. Of all these, the first three may reflect upon the bones of the pelvis. Multiple nodular densities. Look at the right iliac wing, almost bullseye type of nodular density, indicative of or suggestive of tuberous sclerosis. These are actually nodular. It is not bone island. It is in the center of the bone, not on either side of the joint. Cystic angioimatosis, multiple well-defined lucencies, like a hemangioma of the vertebra. Like that, you get multiple cystic type of hemangiomata throughout the skeleton, predominantly in the axial skeleton. Rare periostal reaction. As you see in a classical vertebral hemangioma, here there are no vertical striations because it is cystic lesion. Soft tissues may contain phleboliths. Spleen, lung, and pleura also may be involved in this process. Multiple lucent areas depicted in the ischia and iliac bones. Another case of multiple lytic areas. One on your left side shows huge areas of lysis indicating metastasis or myeloma. That form is rather rare. Now we come to neurofibromatosis. There are three types, type 1, type 2, type 3 also of late they have described, but we are interested in type 1. It is supposed to be hamartomatous disorder, one of the common types in phacomatosis. Caffeolar spots on the skin, list-like nodules in the iris, chromosome 17 abnormality, it is autosomal dominant, plexiform type of neurofibroma producing elephantiasis type of soft tissue changes may be noted. Skeletal lesions, either hypertrophy of the bone or atrophy of the bone, adjacent erosions, intraosseous neurofibroma are also depicted, cystic lesions, medullary streaking. These are all due to actually mesenchymal dysplasia of the bone. Sacrum, look at the large lucent area in the third segment of the sacrum due to neurofibroma. Occasionally, intrasacral meningoceles are also known in neurofibromatosis. Again, dysplastic, look at the obturator foramina on the left side, upper film, thin pubic, superior pubic ramus, thin ischium, and a huge obturator foramina with soft tissue swelling in the thigh, neurofibromatosis. There are some changes in the neck of the femur also. Similarly, you can find dysplastic changes in the bones. One tomogram of the sacrum, neurofibroma, on the left side of L5. CT is quite important in order to outline these neurofibromata and cystic changes. Dysplastic type of sacrum in neurofibroma. I told you earlier, it is a mesenchymal dysplasia. It may involve any bone. Vertebral changes are rather rare, but they can occur. In this particular case, the sacrum and L5 are involved. Now we come to the major entity infections. Otherwise, it is producing osteomyelitis. If it is a joint, sacroiliac joint, there is osteomyelitis plus septic arthritis. Sometimes this osteomyelitis may produce sclerotic changes. It is common more in fungal infections, but in bacterial infections also, so-called sclerosing osteomyelitis, which you can nicely see in a CT. Tuberculosis often produces osteopenia as against bacterial and fungal infections. Again, here note the sacroiliac joint erosion, widening, and then soft tissue swelling, which the arrow depicts in the inferiorly. And when the hip joints are involved, purely lytic and destructive, and occasionally bony ankylosis may occur, as you see in the right side of the pelvis. Inflammatory sarcoidosis and eosinophilic granuloma are some of the inflammatory lesions. Histiocytosis X, you see multiple lytic lesions in the left side of the iliac bone on your right film, and in the sacrum, rounded lytic area in the sacrum. Only histologically you can mention, but what all you can say is it is a benign lesion. Hematological, sickle cell anemia may reflect upon the skeleton, thalassemia, a combination of sickle thal and occasionally mastocytosis. Sickle cell anemia with diffuse sclerosis of the bones. Fortunately, if the vertebra is included, you may find a notch sign on the vertebral end plates, so-called Raynaud's phenomenon. Reynolds, not Raynaud's. Bilateral, look at the sacroiliac joint, left sacroiliac joint, and bilateral hips. Bilateral hips means femoral heads are osteonecrotic. Superimposed infections may also occur, but osteonecrosis and secondary degenerative changes you can see, and sickle cell anemia. Osteonecrosis, classical description both on CT and a specimen. Necrosis with a snow cap type of sign. And avascular necrosis, MRI has got certain advantages because there is no radiation exposure. Not only that, you can see in many views, transaxial, coronal, sagittal, non-orthogonal, and marrow changes you can depict very nicely. Cone view of the iliac bone, look at the mosaic type of appearance of the trabeculae. Osteopenia is there. This is due to hypermedulosis. The same changes one can see in the hands of the bones also and the skull. Mastocytosis, rather rare disorder, spotty or diffuse sclerotic pattern. You cannot on films alone, but it is difficult to differentiate from other sclerosing disorders, but then it is not uniform, it is spotty. It is not like, say, marble bone disease or myelofibrosis. Myelofibrosis also, you may get diffuse sclerosis, but occasionally you can get lytic changes. I always say learning should be enjoyable. Look at the smiling sacrum. The endocrine disorders from acromegaly, hypothyroidism, hyperthyroidism, hyperparathyroidism, hypoparathyroidism, hypogonadism, both in males and females. Hyperparathyroidism, classical, primary, it could be adenoma, hypertrophy, compensatory hypertrophy of the parathyroids or malignancy. Secondary renal osteodystrophy, osteomalacia, etc. One on the left side shows multiple brown tumors in the left iliac bone involving the ischium. Osteitis fibrosa cystic. Similarly, a brown tumor you could see on your right film, multiple brown tumors on your film on the right involving the right iliac bone, pubic bone, acetabulum, right femoral neck, etc. Same CT, expansile, lytic lesions in both iliac bones involving the ischia, brown tumors and primary hyperparathyroidism. Secondary hyperparathyroidism or renal osteodystrophy, you can get osteosclerosis, osteolysis, osteopenia, brown tumors, soft tissue calcifications, including vascular calcifications, and osteomalacia. All of these may not be present in any particular case, but very often the combinations of these, for example, look here, osteosclerosis and osteomalacia are predominating. Fractures, both next to the femur, this is due to tetany in postoperative parathyroidectomy. Hypoparathyroidism, generally you get sclerosis, but then some enthesopathy also you can see. Look at the irregularity of the ischial tuberosities. Calcification of the ligaments also is seen. Cretinism in children, in adults you call it myxedema pattern. Cretinism, 2.5 years old, in the film below, you see barely at 2.5 years you should see a nice epiphysis for the femoral heads. Here you could see faint changes. And 10 years, one on your left side on the top, you could see also changes in the epiphysis And sometimes if you look at the vertebral body, you may see notching, anterior vertebral beaking. Adult hypoparathyroidism, severe changes in the heads of the femora with the degenerative changes. Spondyloarthropathies, how do they reflect upon sacroiliac joints, hip joints? HLA-B27 positive, ankylosing spondylitis, either juvenile or adult, psoriasis, Rider syndrome, spondylitis associated with ulcerative colitis, Crohn's, or any other inflammatory disease of the GI tract. Typical of ankylosing spondylitis, early involvement of hips. Occasionally the hips may not be involved, but sacroiliac joints are involved. Ankylosis, look at the interspinous ligament like a straight, thick, dense line, typical of ankylosing spondylitis. And then sacroiliitis bilateral. And what are the conditions? In the psoriasis, you can get usually sclerosing type of sacroiliitis. Same thing in riders. Only difference between riders and psoriasis is riders often it's not symmetrical. It may be bilateral, but not symmetrical. Degenerative changes, spondyloarthropathies, which I have mentioned earlier, hyperparathyroidism, erosive changes along the sacroiliac joints, rheumatoid arthritis, the narrowing of the space and erosions, and fluorosis due to density, sclerosis. You can get bilateral sacroiliitis also with osteophytosis. One on your left side is Rider syndrome, one on your right side is psoriasis. There is hibernation and erosion also, but as I said earlier, you can't really make the difference. Both of them look almost symmetrical. Only thing is, clinically and radiologically, in psoriasis, most of the time, the upper extremities, including the hands, are involved. In Rider syndrome, most of the time, it is the ankles and feet that are involved. Again, another case of psoriasis, left sacroiliac joint, there is erosion and sclerosis also. Please note, pubic symphysis, erosions and sclerosis, psoriasis. Bilateral sacroiliitis, sclerosing type. There is no reason why there should be a bilateral sacroiliitis, but in fluorosis, you can get this if you also see the osteophytes, and if you look carefully, there is calcification of the sacrospinal ligaments. Another entity is collagen vascular disorders, including rheumatoid arthritis or rheumatoid disorder, scleroderma, lupus erythematosus, dermatomyositis, and sometimes there is overlap disease, not only overlap, mixed connective tissue disorders. Protrusio stabili in rheumatoid arthritis, because of the softening of the bone and erosions, you find this type of changes in the hip joints. Again, rheumatoid arthritis, one in the left hand corner, superior corner, there is osteonecrosis. With or without steroids, you can get these changes, the secondary degenerative changes. Again, rheumatoid arthritis with predominantly erosions and thinning of the acetabulae, erosions on either side of the hip joint, and note particularly the resorption or erosions at the ischial tuberosities. Not many conditions produce bilateral symmetrical erosions. In ankylosing spondylitis, you may find whiskering. In bed sores, you may get unilateral with erosion, with osteomyelitis. Scleroderma, soft tissue calcifications are common. Otherwise, scleroderma joint, hip joints are rarely involved. Fluorosis, as I said earlier, osteosclerosis is the predominant feature. Early on, you may see osteopenia also, calcification of the ligaments, bursae, and interosseous ligaments. They may even ossify later on. Growth lines are seen along the tubular bones, and diaphyseal widening because the long standing, you get modeling deformities also. Endemic areas are there in India, so once you ask the patient where he comes from, it is easier for diagnosis whenever there is a doubt. Calcified sacrotuberous ligaments, the arrow show. Obturator membrane calcification also. Iliolumbar ligaments and enthesopathy is common at the ischial tuberosities. As I said earlier, if you see only enthesopathy, you may find in ankylosing spondylitis also, occasionally in tuberculosis, but usually it is not bilateral symmetry. But if you note the sclerosis of the bones, you can think of fluorosis, ankylosis of, ultimately ankylosis of the sacroiliac joints also may occur, simulating ankylosing spondylitis. But in ankylosing spondylitis, you get osteopenia rather than osteosclerosis. Exuberant enthesopathy, also noted, this is This part of encephalopathy is also noted in disseminated idiopathic skeletal hyperostosis, so-called DISH. But in DISH, which occurs usually in adults, older people, you don't find osteosclerosis as you find in fluorosis. In children, particularly coming from endemic areas, there may be associated rickets also. Look at the widening of the space between the epiphysis and metaphysis, classical of rickets, the complication. Paget disease, reflecting upon the pelvis. Paget disease is rather rare in India, but still we have seen in 12 years at the Nizam Institute of Medical Sciences, 78 cases. So it shows it's not that rare, as is often now quoted. Stages of Paget disease: a lytic phase, a mixed phase of lytic and sclerosis, purely sclerotic stage, and complication, fourth, malignant transformation. The first thing that you notice in the pelvis is thickening of the iliopectineal line. In fact, taking this as clue, the nuclear medical people diagnose on with the isotope identification, hot area in the iliopectineal line, if they see, they immediately think of Paget disease. Increased trabeculations. And one important thing in Paget disease, the process goes all the way to the articular margin. That is important. Again, a mixed phase, lytic and sclerotic phase. The bones are bigger, brighter, and trabeculations are prominent. And ladies and gentlemen, the observations, subtle observations, unless you keep the entity in your mind, unless you suspect, you don't see it. So the most important thing for a radiologist is think of various conditions in the mind and process them and correlate the clinical findings whenever it's possible, and ultimately give a good diagnosis for the benefit